important for us project.
Thank you. Exaggerating. Very nice to see you.
Hello. Okay. And the master.
Do you have a pointer
Pointer. Pointer.
or you can use this one.
Oh.
Bluetooth.
You don't have something like that?
Görüşürüz abi. Good morning, I'm Dr. Zeynoloğlu, his friend.
Hi, nice to meet
Good
you.
morning, welcome to you.
Waiting for the president. He will also be in and making a small lecture.
Oh, okay.
Deneme 1-2. Deneme. Ses deneme. Deneme. Tamam. Deneme. Deneme 1-2. Deneme. 1, 2, 3, 4 deneme.
Sadece buradan mı konuşacağız? Hep böyle mi konuşacağız? Böyle konuşalım. Oradan konuşalım. Buradan başlayalım. Rektör Bey de buradan konuşalım. Sayın Rektörüm, Sayın Sağlık Bilimleri Enstitüsü Müdürüm, Başkanım, değerli dostlarımız, arkadaşlarımız, meslektaşlarımız ve değerli talebeler. Öncelikle hepinize hoş geldiniz demek istiyorum. Bugün tabii bizim çok heyecan duyduğumuz bir gün. So since we have, two guests from abroad, so I would be speaking in English. So we are very excited today, and today is a part of a project that we were trying to collaborate for the last 2 years. And this project is in vitro activation. And we have been trying to collaborate with the pioneers of this field. Professor Hsueh, he is from Stanford University, and he has produced extensively to the literature to our understanding of ovarian physiology. And also Professor Kawamura from Japan, he has also not only been the scientist, also the clinician for realizing this project. And then, following 2 years of very heavy email traffic and personal contacts, I would say, then we submitted a project to our university, and following a long course of IRB approval process, not only from our university and also from the Ministry of Health, we got the approval, and then I would like to express also my sincere thanks and gratitude for our university, and in particular to our president, Professor Hsueh, and also the head of the Institute of Medical Sciences, Dicle Orhan, for realizing this event. So at this point, we started. I also would like to experience the workshop that we started yesterday, and we initially did 6 cases, and we got a grant from the university around $140,000 US, and we did the 6 cases yesterday. We did the unilateral oophorectomy, and there has been a significant workload in the lab, and also 2 embryologists, Yuta and Megumi, were so kind also to join us to experience also all the very detailed processes in the lab. And then we started the in vitro culturing, and we will be autografting the pieces tomorrow. Having said this, I would like to ask our President, Haluk Özen, to the stage to say a couple of words. Please, Professor Haluk Özen. Hocam, canlı yayın olduğu için dışarıdan ona konuşmanızı rica edeceğim.
Tabii. Professor Hsueh and Professor Kawamura and the team. And dear Hacettepe University OB/GYN faculty, residents, and yes, and students. I'm very pleased and honored to host you in Hacettepe University, and I have learned that you were both the pioneers and probably one of the most respectable scientists in the area of ovarian physiology. And this way, you have come for a long way to show and to share your experience with us, both practically and theoretically. This is a big gain for Hacettepe University and all Turkish OB/GYN career standing people. And I cannot express my gratitude, and I cannot even tell you how much I appreciate your visit to Turkey. Thank you very much. And I will continue in Turkish for our guests that have come for this meeting to Hacettepe University. Değerli meslektaşlarım, Hacettepe Üniversitesi olarak ve Kadın Doğum Bölümü olarak yine bir güzel bilimsel etkinliğe ev sahipliği yapmaktan dolayı hakikaten mutluluk duyuyorum. Hacettepe Üniversitesi'de yapılan etkinliklerin düzeyi Hacettepe Üniversitesi Tıp Fakültesi ile orantılı olmalıdır. Ben sevgili Hakan, Sezcan, Lale ve Gürkan'a özellikle bu düzeyde bir toplantı yapıp sizleri buraya davet etmelerinden dolayı 47 yıllık bir Hacettepe'li olarak şükranlarımı ifade ediyorum. Çünkü Hacettepe bir şeyin show off yapılan yeri değil, burada bilimin paylaşıldığı ve paylaşıldığı oranda bilimin gelişeceği bilinciyle yapılan yerdir. Sevgili Hakan'ın liderliğindeki bu takım da bence bunu her aşamada göstermiştir. Ve hakikaten ne mutlu ki bana Hakan gibi öğretim üyelerinin olduğu bir üniversitede rektörüm. Ve bundan sonraki arkadaşlarımın da ben onları da çok iyi tanıyorum, genç arkadaşlarımı da, onların da yarın Hakan'dan daha da iyi olacağına duyduğum güven sonsuz. Sevgili meslektaşlarım, bugün in vitro aktivasyon konusundaki bilgilerinizi muhtemelen tazeleyeceksiniz. Dünkü operasyonlar ve yarın olacak operasyonlarla da bu işlem tamamlanacak. Eğer Türkiye'de bu işlemle bir sağlık sorununa daha şu kadarcık Hacettepe'nin katkısı olacaksa ne mutlu bize. Ve ben bundan dolayı duyduğum mutluluğu başta Kadın Doğum Anabilim Dalı Başkanımız olmak üzere tüm ekibe teşekkürlerimi sunarak konuşmamı bitiriyorum. Hepinize tekrar hoş geldiniz diyorum ve başarılı ve verimli bir toplantı geçmesini diliyorum.
İbrahim, buraya mı konuşuyoruz artık? Hsueh. Now I guess we start the symposium. I, at this point, would like to ask Professor Alan Hsueh to come to the stage. You all know Professor Hsueh. He has been the pioneer of the field, and he has produced extensively to our understanding of ovarian physiology. He is also the inventor of the long-acting recombinant FSH, personally. So it's our pleasure and honor for you to come here to share your experience. The stage is yours.
Okay.
Şuna mı konuşacak İbrahim?
Oh, okay.
So no need.
Oh, I have, yes. I have.
Speak.
Okay. First, I would like to thank Professor Ozen for the opportunity to come here. This is the first time to be in Turkey, and it's very unique experience, and we are looking forward to really seeing the country. As a basic scientist, I would like to thank Professor Iranari because he really appreciates the science, and we start as just trying to understand the physiology of the ovary, but somehow we land on something. I was very lucky to have Dr. Kawamura as a collaborator, and then end up with something that eventually was selected as 10 most important breakthrough 2 years ago by Time magazine. So we are here today because we want to spread our knowledge and how to treat the patient of infertile patients. And so today I will start from the basic science aspect, and then Dr. Kawamura will talk about the clinical applications. So in the ovary, it's very interesting that we really look at only, we have 800,000 follicles at birth, but every month we're really looking at one follicle. That follicle is is really playing the most important thing for the ovary. Each follicle is almost like an independent unit, okay? And this one particular large follicle, antrum follicle, has two functions, and it has the reproductive function because it has the mature oocyte for that particular month. And actually, all the steroid produced, estrogen produced was mainly by that one follicle. Okay, and then in the ovary we face with 3 different diseases, and the first one is premature ovarian failure, or called primary ovarian insufficiency, which affects a small number of patients. But today we're going to talk about how we treat this patient using our understanding of physiology. And certainly the most prevalent one is polycystic ovarian syndrome, which is actually also related to some of the discovery that we made by applying our basic science knowledge to the clinical medicine. And then in the clinical medicine, this interaction between the basic science and clinical aspect allow us to make another discovery, which I will talk about, which will be eventually useful for treating polycystic ovarian syndrome. And then the third one is the ovarian cancer, which also was part of our interesting finding. So the ovary is different from most of your organs in the body because it undergoes tissue and vascular remodeling during each reproductive cycle. Actually, in our adult life, there are only 2 organs in our body that go through vascular changes. That is, you have new vascular, we call it neo angiogenesis. There are only 2 organs. One is the ovary, the other is the uterus. Okay. Other neo angiogenesis actually are tumor, give you the tumor. So, so each cycle we have this change or remodeling of the ovary and leading to lifetime decline of follicle number and quality. The quality goes down with age, the number goes down with age. And then by 51 years of age, there's not enough follicle, and then people went into menopause. So today we're going to deal with particular patients who are around 40 years of age, they already have no menopause. And how are we going to treat those patients? So this is talking about the recruitment of follicles. So we have a lot of primordial follicles on the lower right-hand side, left-hand side, and then some of them start to grow, and then this is where we are interested. Why some of follicles begin to grow, and actually most of them still remain dormant. We call it sleeping beauty. They just stay there and not growing. About 1,000 follicles start to grow every month. Only one of those 1,000 will make to the top of the ovulation. And as I mentioned to you already, if you look at the dashed line, we call the cyclic recruitment, that every month, some of around 20 or so follicles that reach the early entrance stage. But then FSH treatment allow you, the endogenous FSH allow you to give one pre-ovulatory follicle, only one, okay? And above the dashed line indicates those follicles are the ones that produce estrogen. So when you decide whether a patient is menopause or not, you decide on whether they have menstrual cycle. And actually menstrual cycle is an indirect evidence of the ovary function, because only the big follicle produce enough estrogen to give you the menstrual cycle, because estrogen followed by luteinization and then progesterone. So people decide whether someone is fertile or reach menopause or not based on basically whether you have follicle above that dashed line. Okay, and that's not a good indication, because we know there are smaller follicles. Even those patients who are 40 years old and reach menopause for several years, they still have some small follicle. So that's what we're trying to deal with this issue. So we ask the question, what is behind this? And then the literature tells us, actually, in the ovary, in this particular case, in the oocyte, there is an AKT pathway on the right-hand side. You can see the AKT pathway. If AKT is high, it will go serve as a brake to break the FOXO3 effect. FOXO3 by itself is actually make sure all the follicles still remaining as a sleeping beauty. They remain dormant. Okay. If AKT comes in, it will break the FOXO3 action. Then follicle begin to grow. So every month, some follicle, some oocyte go through this process. And upstream of this process is the growth factor. And now we actually know it's called KIT ligand is the growth factor. It will cause a phosphorylation of its receptor tyrosine kinase on the left-hand side, and we show the P on a tyrosine molecule, so the PY, okay? And this process, as any biological process in the body, if you have something stimulating, so every month some follicles have this pathway activated, so AKT goes up, but at the same time, you have to have something preventing it further going too much. So there is a P10, you can see in the middle there. The P10 gene will make sure PIP3 will come back, will not continue to stimulate. If you continue to stimulate this system, you get tumor. Okay? So the body always has this balance. So the interesting thing is, people found out that, as I mentioned to you earlier, FOXO3 is a brake to make sure the follicle stay there, will not grow. And when they take away this gene, every follicle starts to grow. So then you actually have early menopause for the mouse, okay, early reproductive cycle cessation. And then later on, there's another publication. They take away the P10. See, if you look at P10, it's also another brake to make sure, because it keep on coming back, so it don't stimulate too much. So they do an oocyte specific deletion of P10, because if you do a regular P10, over the whole body, then you have tumor, you have all kind of problems. They don't even grow. The animal doesn't grow. But if you have an oocyte-specific deletion of P10, then you will have all the follicles start to grow. Okay, so that was published in 2003. This paper was published in 2008, almost 10 years. It's 10 years now. And what happened, to give you the example, this was published in Science 2008. And if you look at the left-hand side, the knockout animal, I'm sorry, the wild type animal, and then the B are the knockout animal. So, thank you so much. This is the one that in the oocyte, the P10 gene has been deleted. Okay, so what happened is day 5 in the mouse, day 5, everything is sort of at the early stage. The follicle just beginning to grow, so you don't see much difference between the two groups. And then by 35, you suddenly see the one that has P10, that break taken away. Every follicle is growing. So all this higher magnification, all this big follicle, oocyte, okay, the ovary become bigger. But because all the follicles start to grow, and then you run out of follicle. So by 16 weeks, there's nothing left. Okay, so this is almost like the patient premature ovarian failure, almost like that situation. So, but this data really tell us this pathway is so important. So what we did was, we asked the question, as I mentioned to you earlier, actually for those patients who does not have any menstrual cycle, but some of the patients may still have small follicles, can we actually make sure those follicles start to grow? So there are two ways, right? One is take away this break, which is almost impossible because this is a transcriptional factor. But this is good because actually when that paper was published in Science, the science editor wanted me interview me and they want to write a commentary. I say, wow, this is perfect. Because if you just use an inhibitor, we know they are inhibitor for P10. And if we can do this outside of the body so that it does not affect the rest of the organ, then if we just say inhibitor, this, okay. So later on, I visited the original lab who published this work. I said, are you guys doing this? He said, no, we're not doing this. Okay. So I said, okay, we will try to do this. So we got the inhibitor, which is very easily to get, and we also formulate a peptide, which is called 740YP, which is actually the intracellular region. Only 9 amino acids, but we make sure one of those amino acids, the tyrosine, is phosphorylated. So we take the PDGF receptor, intracellular region, and phosphorylate it. And then we fuse to a fly protein, which will pass through the membrane. So now we have a 25 amino acid peptide. This peptide, we say, we can take the ovary out and incubate with this peptide, and then this pathway will go on, and then this will break, and then the follicle should start to grow. So we set up a very simple experiment. We took the day 3 animal, as I showed you earlier. Day 5, everything is still very early stage. We want to make sure it's even earlier, so we take day 3 animal. And we choose a very simple experiment. One ovary we treat with P10 inhibitor or the PI3 activator. The other side, we don't do anything. And then after 2-day incubation, we put it into the kidney capsule so that it has the best vascular system. So the follicle, if they are activated, they have the best vascular system. It will give the FSH. And in animal, we know it took 2 weeks to grow into pre-ovulatory follicle. So this was published in 2010. And this is the result. So one side, and this is the counterpart, left and right. So you see this is smaller, this is bigger, and you take it out. This is adding the P10 inhibitor. You see every single animal, the pair of the ovary, there are differences. And then you use the P10 PI3K activator, you also do it, and you add the two together, it even seems to be bigger. So this provides us the concept that is, if we activate this pathway outside and then allow the follicle to grow, we should be able to actually get the mature oocyte, and this is the embryo culture, and then we can get the baby. So that idea is fine. Then we went into Dr. Kawamura did this in Japan using the patient, using the human cortical cubes, and it's very difficult to get this, but we know in the human ovary, all the primordial follicles are on the outside, near the cortex region. So he got some patients who have 2 pregnancy and decide not to have any more pregnancy, and then they volunteer to give him a little piece of the cortex. And this is where the basic science and clinical collaboration becomes so important. So he can get some of these small cubes, cortical cubes, cut into very small pieces, and then some treated with the inhibitor and some not treated, and then do the 2-day incubation the same way, and put into the new mice so that there's no immune problem. And then in human, it takes 4 to 6 months. So he actually injects this FSH every 2 days for 6 months, and it's an incredible experiment. And then you know how anxious he was when the last day when he had to kill the animal. First, we make sure we give ACG so that it's like the human. We give ACG to allow the oocyte to mature, but not long enough to ovulate. Okay, but actually it cannot ovulate anyway. It's in the kidney capsule. But anyway, so when he took out the ovary, the kidney capsule, you can see control, and this is treated. The treated one is almost as big as the kidney. So that told us everything works beautifully. And then he very detailed cut through all this ovary, and then some of the section he can see oocyte, and those oocyte are already mature. So that means this whole thing actually can work in patient. So Dr. Kawamura now actually, this is a good chance to thank him. He actually gave up a national university position, go to a private clinic because our private university has a professor that has all the POI patients in Japan. So he went and then worked there. Now we can talk about this because it's working. He was taking a big gamble. Okay, but those patients are few, only 1%. But almost all the Japanese patients went to the Semineri University, and then he can have access to the patient. And then in those days, oocyte donation is the only option. Okay, he say, well, based on what he knows about science, he should be able to help them. This is his experiment, initial experiment, and he took out the whole ovary and then cut into small pieces and then cryopreserved them. And then in this case, he fragmented the ovary furthermore because he wanted to treat them with the drug to make sure they are small enough so the drug can really go to the ovary. And also, he wanted to make sure that when you auto-transplant back into the patient, the vascularity is good. So he did all this cut into small pieces and then add the drug, okay? And interestingly enough, these are his first 3 patients. It's incredible the collaboration between basic science and the clinician, because he began to see that some of the patient, this patient is what we expected. After 6 months, it's about what the time you need from primordial follicle going all the way. Okay, he can get pre-ovulatory follicle, and some of the patients, like this patient, within 3 weeks he can get 2 pre-ovulatory follicle, get oocyte. So, patient certainly very happy. The doctor also very happy. Okay, but I was totally puzzled. I say, what's going on here? Why patient should look like this and not look like this too. So this is where the interaction between the basic scientist and clinician, and also for Kawamura, he knows both sides. It's become so interesting. So we asked the question. You go back to literature, the polycystic ovary, the second syndrome I was talking about, affecting 5 to 10% of women of reproductive age. And actually, if you go through the literature, in 1935, when they first described the PCO, they actually called some people still call it Stein-Leventhal syndrome. So the Stein-Leventhal were the two New York City physicians, and they look at this patient, very strange, they have amenorrhea. But then, when they open up this patient, they see polycystic ovary, and chalk-like, very thick outside. And then nowadays, we look at the ultrasound, you can see a lot of follicle. They sort of arrest there. They just only go to early entrance stage. And then what people have been done is, in those cases, they did wedge resection because they want to do a histology to see what happened. So they took a piece, a wedge of the ovary out, and all the patients begin to cycle themselves for 2 or 3 cycles. And later on, people do this laser drilling. They use laser to burn the ovary, and they do the same thing. They can start to cycle. So, but nowadays, people don't use this now because, you know, the drug company push you to use FSH because that's the easiest way, right? So, but I still remember the literature. I say, wow, this is strange, because when Dr. Kawamura did all this work, he actually did fragmentation here. He always cut into small pieces before he actually add the drug and then put it back. So, is it possible? How could activated dormant primordial follicle grow into pre-ovary follicle in just a few weeks instead of 6 months, 4 to 6 months? Okay, are we unleashing the growth potential of arrested secondary follicle? Maybe some other follicle, bigger follicle, also are arrested. Maybe the ovarian fragmentation is doing something to it, and maybe this is the same as you unleash the growth potential of the early entrant follicle for the PCO patient. So we set up another experiment. This is almost a crazy experiment. I cannot convince the fellow. I have to talk several times. I say, this is a worthwhile experiment. And what we did was we used day 10, which has secondary follicle. Only in the mouse, they only grow the biggest one are the secondary follicle. And what we did was, one side is the intact, the other side just cut into 3 pieces, not adding any drug. Okay, and then we do the same transplantation. And then we cannot wait for 2 weeks now. We have to wait only 5 days because secondary follicle growing to pre-ovary follicle take very short time. So we do a 5-day treatment, and this is what happened. One side, 3 pieces of the other side, and they all start to grow. Just cutting the ovary. The biomechanical changes of the ovary probably change the tension. Just like PCO, you have very strong tension because the outside is very thick. You change the tension, and then they start to grow. Okay. And I couldn't believe the data, and I tried to convince Dr. Kawamura. He repeated the whole thing in Japan, also the same thing. As long as you cut, it grows. And then we did more detail. So if you take the ovarian weight, day 10 ovary is this, day 15. So this is just normal situation. The ovary is follicle are growing. Okay. If you give FSH, because on those 5 days we give FSH, FSH didn't do that much. Okay. And then in the original experiment was cut into 3 pieces, wait for 24 hours. 48 hours, 2 days. We always do 2-day drug treatment. We now only do 1 day, 2 hours, 1 hour. Doesn't matter. The black one are the cut one. Okay, so just cutting by itself, very short time. You don't need anything else. And you can cut 2 pieces, you can cut 4 pieces. Doesn't matter. Anytime you change the tension, the biomechanical, you do something to the ovary, they are going to start to grow. So we repeat enough, but you know, it's most difficult thing. And this is the histology. One side, the other side cut into 3 pieces. Basically, when you look at this, it's only the bigger follicle, there are more bigger follicle. So it's not really changing the number of follicle, because if you count the number of follicles, the black one are the cut one, okay? Primordial, primary, maybe primordial change a little bit. Secondary, early secondary, late secondary is higher. And pre-ovary is higher. And these are the big follicle. That's why I give you the size change, okay? So really the big change is And if you look at the percentage of follicle, you can see this axis dashed line on this side is totally different from this side. The total number didn't change that much. It's the follicle that begin to grow that makes the difference. Okay, so this is very nice. We can repeat it. We can really believe this data. But what is the mechanism? Okay, and actually today when I was driving down, I was still asking the question. I say, in Turkey, do you allow to teach evolution? Just a curiosity. This whole thing was resolved by an evolution story. At least for me, I believe everything is based on evolution. If you don't understand our evolution, a lot of questions in medicine cannot be explained. So one day I was reading, so this is the Stein-Leventhal over 70 years ago. They found this wedge resection, and our recent data showing the mouse fragmentation can do it. And the mystery was solved by a 700 million years old story. That is, we have our common ancestor with fly 700 million years ago, and there is a system already in place in our common ancestor with the fly. It's called hippo tumor suppressor pathway. Okay, this is the pathway. The gene I show here are the human gene, the mammalian mouse gene, and this whole pathway is served as a brake for the cell. That is, the most important thing is this downstream one called the YAP gene. Okay, the YAP gene usually cannot work. Any of your organ reach its proper size is stopped because this brake system is there. Hippo signaling is working. If hippo signaling, this pathway is blocked, it's a tumor suppressor pathway, then you have tumor. Okay, so our tissue all stop at this stage. In the fly, they have a very interesting transgenic approach. They can change every single cell, make it transgene in the cell. So they can knock out any of the pathway genes, and then you can have those single cell form tumor. And that's why later on fly people always want to give funny names. So they say, well, this looks like a hippo skin. So they call it hippo signaling pathway. This same pathway is conserved in our system. So in the mouse, they can take away the MST, and MST in the mammalian system has 2 genes now. You have to take both of them away, only in the liver, and then the liver become 4 times the size. Okay, so the liver, this system is working once liver reach certain stage. But once you damage to the liver, then this system begin to grow. Okay, and also you take away the gene. Okay, because if you cut some piece of liver, they begin to regenerate because this pathway somehow monitor and say, well, this is too small. Even in the heart, this gene, SAV1 gene, if you take away the knockout of the heart in the mouse, they become 4 times the size. And actually, now later on I show you, this pathway is involved in ovarian cancer formation also. So it's a tumor suppressor pathway. A lot of the tumors nowadays, people check, they found out that sometimes the YAP is overexpressed in those tumors. So it's a overall for all our things in the body. So in the ovary, we first did was we check all those genes. They are all in the ovary. Okay. So then we say, well, if this is real, then we do the cutting. Maybe the YAP will go to the nuclei, and then it will cause the downstream growth factor to change. So we did the cutting, whole pieces, YAP did not change, phosphor YAP goes down, and then actually the YAP go to the nuclei with this treatment. And then we can easily see it by doing the staining. This is the intact side, this is the cut, the left side or right side. You just cut into 3 pieces, you do the staining, you see they all become very dark because they all concentrate into the nuclei. Okay, so with this, this is just morphology, but the most important data is the fly people already tell us downstream are CCN growth factors. So fly has 1, we have 6. So we did every single one of this growth factor after cutting. This is a dashed line and no dashed line. I'm sorry, there are two dashed lines, they are all cutting. And this is solid line is controlled, no cutting. Why there are two lines? Because one we did the grafting, just to be sure. Okay, the other we did not do grafting, but you can see among 6 of the growth factor, 4 of them goes up, just cutting. Okay, so now what we have found is, we found new growth factor in the ovary. Follicle stimulating factor now, okay? And this is just to show that we can actually use the CCN2 antibody, we can block the follicle weight increases, okay? So showing that endogenous doing something. And this is actually very difficult experiment. Dr. Kawamura have some of the human cortical cubes, and he throws away, and then he can do the cutting before he put into the patient using the same approach. Then just do RT-PCR for 1 and 3 hours. You can see all the open ones are the ones that's cutting. The black ones are not cutting. And all 4 growth factors we found in the mouse also works in the human. So that means his cutting really do something to the ovary in terms of growth factor. And then now we have 4 new growth factor for the ovary, follicle growth factor. We just took the ovary explant out from day 10 animal and then treat them for 4 days with FSH, which they should stimulate, so increase in ovarian weight, and then different doses of this 4 growth factor, they all do it. So that means the growth factor locally produced by the ovary after our biomechanical change is changing some biochemical things and then allow the follicle to grow. And actually, the fly people have done some more. They know they are apoptosis inhibitor also. So we check, there are 7 of them, we check 2 of them will go up. Okay, so they don't die. The follicle don't die and they grow. So then it comes to the big question that is, what is going on here? Why we cut, and then this whole pathway will be disrupted, and then YAP go to the nucleus, and growth factor goes up, and apoptosis inhibitor goes up. Okay, and the nice thing about the fly system, knowing this conserved system in fly and human, is fly has only 10,000 cells, and they can do in vitro culture to use a YAP reporter gene to see whether the YAP go to the nucleus, and they can do the downstream reporter changes. So they did RNAi screening of all 10,000 genes in the fly system, and they found all the genes that upstream of this change are actin polymerization genes. Okay, so our hypothesis then become our cutting probably changed the actin, the globular actin, G-actin, into filament actin, because actin is the most abundant protein in the cell. Okay, so maybe that's what happened. So actin accounts for 10% of our cell protein, and this biomechanical changes is taking place at the actin level. So then we can actually measure the G-actin and F-actin. And then with the intact or the pieces, if we cut into pieces, we can see a very transient, very fast change in the actin, G-actin become F-actin. But that's difficult experiment, as you can see. Only a shortened transient change, because if the change lasts for long, the cell will die anyway. So, but knowing this knowledge, we can actually design new things now. We can use actin promoting drugs. Instead of doing the biochemical change, we can do actin promoting drug, and then we can see that actin polymerization will take place, and then we expose our ovary to this drug for 5 different doses, and then do the grafting, just like I showed you earlier, and then the ovary begin to grow. Now we don't have to cut, we just add the drug. And knowing the drug, then it's very interesting, because there is actually a natural molecule inside the follicular fluid actually is called sphingosine-1-phosphate, and literature tells us it will cause actin polymerization. But the S1P in the follicular fluid is always bound by the high-density lipoprotein, so it can never do anything. But we can add from outside. We can add this for 2 days. Now we have to do a little bit longer. And then we follow by the grafting. Without cutting the ovary, just adding this drug, this natural substance, and you can see the black ones are different doses, treatment, and then initially this actin polymerization by this treatment, S1P will cause it to increase. So now we are trying to figure out whether S1P can be used to be delivered locally to the ovary and allow follicle to grow, but that's still ongoing. So to summarize the story, we are talking about G-actin after cutting become F-actin, and then it will suppress the hippo signaling pathway so the YAP can go to the nuclei, and then downstream growth factor and apoptosis inhibitor. But when we went through all the literature, it becomes so interesting because the literature already tells us when do all this GWAS, genome-wide association study, there's a lot of effort doing this, and then in the PCO patient, they found the YAP. Okay, and in the ovarian cancer, a lot of ovarian cancer, the YAP ovary cancer, YAP is higher. So it's a tumor suppressor gene, so that's fine. Okay, and when people look downstream of the POI patient, they look at the gene copy number changes in the POI patient, they found our BIRC1, which is the apoptosis inhibitor. So they found this patient. And in upstream for the actin polymerization gene, there is one unique family. Just this mother and daughter both have this, and that's due to a chromosome translocation, and the translocation site is this DIAPH2, which is involved in actin polymerization. And there is also another group, they did a massive, large number of patients that have slightly earlier menopause than the normal one, but not very extreme, just a few years. And they also found another gene which is in this pathway. So it becomes very clear that this pathway is very, very important for the ovary function. So now go back to Dr. Kawamura. He will talk about more. This was his original study we published in 2003. And the patient 37 years of age, and then already average 7 years of no menstrual cycle, amenorrhea. And then he took out the ovary, and usually he take a small piece, side piece, and then check. And half of them have no follicle. Those patients insist to go on the whole program of following up to see follicle, but none of them have follicle the growth later on. But the remaining, this 50%, in the old days were cryopreserved, and then fragmentation with the drug, as we mentioned earlier, and then auto-transplant, and some of them will begin to have follicle growth, and then in vitro activation, and then have baby. And this was his first baby, and then and 2014 there's another one, and then he taught this method in China, and 2016 another publication. And this is an interesting one because in this group in China, they follow not only this, they also done the AMH, which I will talk about. But so this was one baby delivered, and yeah, the third baby, and now Dr. Kawamura have sort of summarized all this, and I'm sorry, let's see, this one I already mentioned. This one, there's some mess up of my, am I going backward? Yeah, I'm going backward. Okay. I'm going backward. No, sorry. Okay, good. Yeah. Yes. I'm sorry. Now it's right. So you can see this is very interesting because the AMH level in those 6 patients, only one has AMH. The other one do not have AMH. AMH is being used to sort of tell you what's really going on in terms of whether they have some follicle left. But it's not actually very, very accurate approach. Yes. So we can actually see the AMH, which I purposely put this slide here, because for PCOS patients, they have high AMH level, but they only have allowed this follicle at the early entrance stage. AMH really is produced by this type of follicles. And in the normal cycling woman, your AMH is actually not that high. Okay, and some of these patients, a middle-aged infertile woman, you can have medium or low AMH. And then in some of the POI patients, you have no AMH, but they still respond to the treatment because they have some very small follicles. And so that's where I think AMH is really a paracrine hormone that's produced by the ovary and doing something in the ovary. Whatever you see outside is leakage. It does not really tell you the real thing. Okay. Am I pushing this? Okay. And regarding the safety, a lot of people worry about it. Actually, we have people from Spain contact us. They want to do IVA, but they say, well, our government does not allow us to do it. But the safety use of H10 inhibitor has been published by the original Swedish group. They have followed long-term monitoring using the rodent system of the progeny mice, showed that the mice were reproductively active and were free from any overt signs or symptoms of chronic illness. The result that this is a safe method. Okay, but those are the animal study. And for our study, Dr. Kawamura always washed the sample very expensively to remove drug before grafting back. And then he has checked more than 100 patients that never see any abnormal growth. Okay, so in that sense, it's probably very safe. But until you do large scale, you'll never know. Okay, so, but because of the safety issue, then a new approach has been established. As you know, this earlier method was going through the cryopreservation, fragmentation, and then this become an optional step. Actually, some centers do not do cryopreservation. The success seems to be higher. This is a 2-day treatment after cutting, and then you can get, but involve 2 surgeries. Okay, so the Spanish group talked to us, and then we discussed with them. They say, oh, our government do not allow to use drugs. That's fine. If you choose patient that has recent menopause, okay, that means they still have some bigger follicles. They don't just have primordial follicle like Dr. Kawamura has to do, because that's you go in any new procedure, you have to go to extreme cases. So in those cases, he had prolonged menopause. Okay, so because our process actually involves 2 things. One is AKT stimulation. The other is the Hippo disruption pathway. So we talk to the Spanish group, and they say, well, if they use recent menopause, maybe they just do the fragmentation. And that involves only 1 surgery. And then they actually put back to the ovary itself, because the ovary is still big enough because it's very recent menopause. Sorry. the drug-free IVA has a limitation. You have to choose patient that's very recent menopause, but it has the advantage because you have minimum damage to ovarian blood supply because you do not remove the whole ovary. No need to use the drugs and avoid potential follicle loss. Even 2 days outside, you can have some because it's not a normal situation. And then only one surgery is involved, and spontaneous pregnancy is even possible if you put back to the ovary. And this is their initial result. They published. They discussed this in a workshop last year. They have 14 POI patients, recent menopause. 4 of them, they can obtain embryo. And actually, while the embryo were frozen, 3 of them become spontaneous pregnant. And that's why it's so interesting, this approach works. So, go back to the follicle development slide. You know, the ultrasound can only tell you anything above this line, which is the same thing as I was mentioning about the regular menses or no menses. Okay, so because we want to see whether the follicles are the smaller follicles in the ovary, so we set up a new approach. What we did was we took the FSH because once the follicles start to grow, they have FSH receptor. So what we did was we conjugated FSH. We tried to do live imaging of FSH based on FSH conjugate to a near-infrared dye. Near-infrared, you can actually see through the whole animal. And using this dye, we can see granulosa cell, we can see very nice signals. And this is a tumor cell, has no signals. Okay? And this signal can be competed by regular FSH. So using this approach, we actually found that after you inject the animal with this dye, the ovary, this is the kidneys, which all the dye will go there anyway, eventually. So you begin to see, after 150 seconds, you begin to see the ovary begin to light up. And then we can take the ovary out and then do confocal, and you can see very nicely the follicle are actually there. And we choose the animal at day 18 of age, which only have secondary follicles. They don't have entrant follicle yet. And you can see the follicle very nicely in the ovary. So theoretically, this approach, this fluorophore has low cell toxicity that's rapidly cleared from the body that may be used to detect pre-entrant follicle for this type of patients. And you know, as any research, you always find something surprising. We found FSH is actually found in the bone and in the adipose tissue. So there are literature now saying the menopausal woman, the high FSH is actually bad for their bone and for their obesity issue because there are FSH receptors there, which I will not discuss in detail today. You can find there are recent papers dealing with this. So, so for the IVA therapy, the original therapy, now we put all the follicle in this scheme, and you can see from smallest follicle grow to the bigger one. This is the regular cycle, all good FSH responders. This is the extreme case, and now there are at least 6 patients successful in Japan, 2 in China, 3 in Spain, and then 2 in Denmark. And for the middle-aged women, they have bigger follicles, but they once in a while will ovulate. And this patient, there are some cases, successful cases also. And so theoretically, this approach may go into other populations. And now go back to the real basic science issue, that is, the PCO is very thick outside cortex, and they have stiff cortex. And we know that if you grow cells under very rigid conditions, the Hippo pathway is disrupted. So we can hypothesize in the PCO patient, because of biophysical changes in the outside, you can have Hippo pathway disrupted, and CCA cell can have hyperplasia, androgen can go up, and then you can have other subsequent changes. And this explains why you do wedge resection or ovarian drilling it disrupts the Hippo signaling pathway, and you get the same result. So now the question is, in the future, can using this Hippo understanding of the Hippo pathway to treat the PCO patients? So theoretically, in addition to the POI patient and the recent menopause patient using no drug IVA, maybe the puncture or incision or intraovarian SYP injection can be used for resistant ovary syndrome, poor FSA responder, and also the PCO patient now. So I would like to thank Dr. Kawamura for all the collaboration, and without him, without the interaction between the basic science and the clinician, this project will never take place. Thank you very much.
No, you stay here.
Okay. Can I have mine?
Since we have live transmission also, I guess we have around 100, gynecologists just, working with live transmission. We will be using this microphone. So the question, the lecture is open to question and comments. Is there any comment or question from the audience?
Just one comment, if I may. Thank you for this excellent lecture. First of all, I must say that I missed science. Thank you for this excellent lecture, because I have been listening to urology lectures for almost 2 years. It was excellent, although I understood probably at the most 50%, but still excellent. Secondly, you have shown us the difference between technician surgeon and surgeon scientist. And this is important for OB/GYN people, urologists, orthopedics, everyone. It is easy to be a technician surgeon, but you have to know the basic science behind it. Thank you very much. And I apologize that I have to leave and cannot listen to Professor Kawamura. Thank you.
Thank you so much. Thank you.
Yes.
Thank you very much for this nice talk. I'd like to ask, we know that from the science paper that if we knock out P10 or the P10 AKT system, then the mouse went to POI, right? Mm-hmm. Because of the over stimulation and the burnout system comes out. So while doing these kind of experiments, while recruiting patients in this kind of experiments, do you check the P10 activity or maybe the primordial follicles if they are already there or not? Because this patient may go to the POI because of the some unbalanced P10 and AKT activity. Thank you.
Yeah. Sorry. Sure. Okay. No, we don't check P10 activity because P10 activity is very transient change, so you probably would not be reflective what's really going on. And Dr. Kawamura always check for the residual follicles. But, this type of patient are desperate. Even you tell them there's no follicle in the adjacent section, they still say, we want to try. So actually, most of his patients continue to go through the whole procedure because they want to have their own children, genetic children. So that's the thing we are facing. That is, even you predict, they don't believe because you take a small piece outside, you can never tell what's remaining piece, there are any follicle or not. So.
There are two questions from live transmission. The first one is, what will be the place of this technology in poor responder patients? You have partly covered. And the second one is, even though this procedure is experimental, there might be the concern of, the cancer, for some time of cancer So what would be your comment in this context?
So in terms of the cancer, I already discussed the safety issue. And certainly the whole approach is doing this outside of the body. And then you only put back a very small amount of tissue, and then you always wash out all the inhibitor. The concept is this: once the follicles start to grow, they don't go back. Okay, you wake them up, and that's what we're doing in the in vitro system. And then we wash out all the drugs, so that at least up to now there have never been any side effect that has been seen. And in terms of the poor responders, we need more data in order to go on. At this stage, no, it's not really enough evidence, enough data accumulated to answer that question.
Also, there is one question from live transmission. It's a very interesting question also. I was also very curious about this. So the effect of puncturing of the ovary during egg retrieval. So assume a patient with limited ovarian reserve, and then with puncturing and doing consecutive IVF. I mean, it would be very interesting to look at the number of eggs retrieved. So the effect of puncturing per se on the number of oocytes harvested by itself.
If you talk about puncturing and then see how many oocytes retrieve, that you cannot see changes. It's really just puncturing itself. But there are evidence to show that if you do some kind of puncturing for a PCO patient, the follicle will, they begin to cycle. So that's a separate issue. That is, you change the biomechanical changes in the ovary by using puncturing. But if you're just saying the puncturing to retrieve the oocyte, this method will not do anything. The Hippo pathway is not involved.
So what you say is that the puncturing by itself during egg retrieval would not inhibit the hypoxia. It's not enough trauma.
Okay. I understand. Yeah. That may cause trauma, but that whatever happened to the follicle growth is a delayed process. It doesn't happen right away, right?
No, I mean for the consecutive
Sure,
cycles.
for consecutive cycle. Actually, if you read through the literature, there are several papers saying that if they do the puncture, actually the follicles start to grow. But the problem is, depends on who is puncturing, so those data can never really be reproduced. That is, people try it and they don't work. So actually, Dr. Kawamura is trying to set up a mechanism that is, your puncturing mechanism itself is controlled. That is, if you put your whatever probe at a certain stage, and then it give you a limited or controlled puncturing. I think that's the future. That is, if everyone is doing themselves, you can never repeat those data because some people's hand is stronger than the other. So Dr. Kawamura is trying to set up a device. Then you can do a controlled puncturing. Yes.
Any questions or comments?
Thank you very much for your excellent presentation. Actually, my question is a little bit out of the session. From the first slides that you showed that, you know, the role of epidermal growth factor and growth factor for, you know, to stimulate the follicles. There are a lot of papers about the stimulation of the patients with growth hormone, and some of them are, you know, good, and some of them it's not, you know. How do you explain it, you know?
Yes, growth hormone is a very interesting issue. That is, if you give FSH together with growth hormone, does it help or not? If you look at literature, growth hormone is somehow, actually we have done it ourselves. Growth hormone receptor is present in the ovary, and growth hormone treatment will increase local IGF-1 level. So if IGF-1 can help FSH, which there are enough data to show that, then this may work. Okay, but on the other hand, because you are injecting growth hormone from outside and not monitoring the local IGF-1 level, so the data is up and down. You can see the literature. Some people say it works. Some people say we don't see anything at all. So the major thing is we do not have a growth hormone deficiency state. Maybe there's enough IGF-1 always there doing something anyway. So adding from outside may or may not help. And unless you have a subpopulation that you know IGF-1 is lower, then maybe adding it from outside will help. Yeah. So that's still a very sort of controversial issue, yeah, in terms of growth hormone action.
When I read this one, you had a lot of studies about the recombinant, drugs. As my personal, just observation that, I'm not talking about, scientific, but when we stimulate with the patients with the recombinant LH, compared to the, the urinary FH, there is a difference that I think. How do you explain it?
Yes. Yes. Recombinant LH and the urinary LH. Okay. Actually, in both situations, for LH and FSH, we are dealing with glycoproteins. The glycosylation state is very difficult to control. So our pituitary LH glycosylation state is not the same as the one they made, for example, in CHO cell by the company. And company doesn't want to tell you this, but the carbohydrate side chain is not easy to control when you synthesize it. So whatever they have, they show it's effective. They just stick to that, and they don't really try to mimic the endogenous level, the glycosylation state. So, give you the best example of glycosylation is the one we try to do is we make FSH, then we found out that patient get FSH injection for a long time, up to 7 days before the follicle grow. So we try to make a longer acting FSH. Then we add the CG. CG has a long half-life. So we found out it's actually the C-terminal end of the beta subunit of the CG that makes it so effective. Because basically, the beta CG is the same as beta LH, but in the primary evolution, the gene duplicated. Again, back to the evolution story. And then at the end, the CG has some extra 30 amino acid because one nucleotide was deleted. So it reads there and there's no stop codon. So it continues to read. And in that extra C-terminal peptide, ICG, what gives you the long half-life, and it's due to glycosylation changes. So glycosylation can make a lot of differences as you clinically already see something. But the company will never tell you this is different glycosylated than whatever the body is making.
Any questions? Buyurun. Tabii. Bir dakika mikrofonu kullanırsanız.
Her şey için çok teşekkür ederim. Çok güzel bir sunumdu. Bu aktivatör ürünleri direkt overe enjekte etsek acaba nasıl bir cevap alabiliriz?
The question is, what will be the impact as an alternative to direct injection of these P10 inhibitors and AKT stimulators into the ovary?
Yeah, I don't think you can do that because this pathway is so important for tumor genesis. I mean, what the major advantage, and we call it in vitro activation, is we do all this outside. You cannot do it inside the body. If you do that, you may have a lot of other side effects. So that cannot be done. No.
Could you tell us more about this S1P? I mean, the local injection of S1P.
Yes.
And also, finally, your very recent research about this FSH receptor visualization as an alternative to histology. It's very interesting.
Yes. First, S1P. S1P, we just need to find a company willing to make this compound in a sort of in a fashion that can be put into the patient. So we haven't found a company that want to do this. And in terms of the
what's the role of S1P in the normal menstrual physiology? as you told, it's very highly bound to high-density lipoproteins
Yes.
in the follicular fluid.
Yes, yes.
In normal physiology.
The S1P, at least in the ovary, it does not seem to be working because it's part of the serine component. S1P has 4 different receptors, and then it plays different roles in terms of the regulation of the hippo signaling or just in different tissue. Depends on the amount of the binding protein. If under certain conditions, which I do not know, maybe in other tissue, this binding component is not there, then it can do. S1P has its own signaling pathway. So no, it's very clearly elucidated already. And the new method we're trying to do is trying to visualize the FSH receptor in the live animal and eventually in the patient. So now the question is, again, in terms of clinical aspect you are asking, is any company willing to go through a trial to show the safety of this compound? I mean, we know it has very short half-life, it probably will be safe, but before you put into the patient, you always need to figure that out. And actually, there's a side issue, because this can be used to check the bone density also, whether there is enough interest, especially osteoporosis is a major issue for menopausal women. Use this as a monitoring of the bone issue. So there may be some interest, but we haven't really reached that stage.
So I guess the questions and comments are over. Thank you,
Thank you.
Dr. Hsueh. And this time the stage is Professor Kawamura.
First of all, I'd like to thank Professor Hecken for inviting me to be here. And it's my great honor to give a presentation on behalf of our Japan IVA team. So first, I'd like to show today's agenda. So first, I'm going to talk about the basic background on the POI. And then we'll talk about a little bit about the translational studies for IVA. And mainly I will talk about the clinical application. And we'll talk about its future studies. Okay. So let's start with the background POI. So here I'm showing the change in follicular number during the woman's life. So all follicles are generated during the fetal stage. And after birth, their numbers continue to decrease due to the activation of dormant follicles, as already Professor Hsueh mentioned, and for the development. And also on follicular atresia, it also occurs. And once the number of the remaining follicle reaches to the less than 1,000, so the activation follicle arrest, resulting in the menopause around 60 years. And among dormant follicles, up to 0.1% follicles select and activate per cycle under still unknown mechanisms. So the activation arrest when the number of residual follicles reaches less than 1,000 are already mentioned about it. So now we have one disease, one serious disease. The name is a primary ovarian insufficiency, POI, also called as a premature ovarian failure. diagnosed by an amenorrhea before 40 years of age and hypogonadotropic hypogonadisms. These patients show the infertility and also the symptoms caused by estrogen deficiency, such as hot flashes, mood disturbances, sexual dysfunction, etc. So in the PI cases, the follicles decline very rapidly compared to normal women, or they have very limited numbers of PI, the remaining follicle at the birth. So then, anyway, their follicles all decrease before 40 years at less than 1,000 follicles. That's why they cause menopause. And the HRD or the POI affects an approximately 1% of women. So I think it's pretty high. And it's caused by genetic abnormalities. Most famous one is the Turner syndrome, lacking an X chromosome. And also the CD triplet gene abnormality is reported in the FMR1 gene. And also, some patients have autoimmune antibodies, but their exact role is still unknown. And of course, iatrogenic one, if we are going to the extensive ovarian cystectomy and partial oophorectomy and chemoradiation therapy, all cause an iatrogenic POI. And of course, unfortunately, I think that around 50% is still unknown causes. And because of these features, actually, the features are recurrent follicular growth and ovulation, and exhaustion of ovarian follicles, and the patient, of course, has a few residual follicles, less than 1,000. And that's why if we try to measure the MH levels, almost all the patients showed undetectable levels. So because of these specific features, patients were really resistant to traditional gonadotropin treatments and egg donation. This one is the most successful treatment option, but the patient really want to conceive using their own eggs. So now, we still have some residual remaining follicle inside ovary, even in a PI patient. So we have said, is it possible to activate residual dormant follicles in a PI patient? So the method is already introduced by Professor Hsueh, and the key molecule is, the key pathway is this one, the PI3K pathway. So, then the next question is it possible to activate residual dormant follicle in PI patient artificially by transient PTEN suppression and PI3K activation using some drugs? So this part is already mentioned by Professor Hsueh. We use a PTEN inhibitor and a PI3K activator. Again, here I remind you that what we have done is in the translational studies using human ovarian samples. So we obtain human ovarian cortical fragments from the patient. They are the benign ovarian tumor, of course, with an informed consent and IVA approval. And then divided in two groups. One is a control. The other one is a PTEN inhibitor treatment. At that time, we just used a PTEN inhibitor, but later on, we confirmed both PTEN inhibitor and the PI3K activator treatment was more effective. And then, after the 2 days treatment, we grafted an ovarian fragment into the SCID mice, severe immunodeficiency mice, to avoid rejection between human and mice, and then treated animals with an FSH. Of course, to try to increase the endogenous FSH level in our mice, we remove the ovaries in the mice. But for just guaranteeing, we treated animals with an FSH for 6 months. It takes very tough experiment. And then finally, we try to expect to get a mature human oocyte. So here, these pictures are already shown by Professor Hsueh, and I skipped this one. And here's the histology. And this one is a 36 hours after HC treatment. That means that we can expect to have a mature M2 stage oocyte. So here, the follicles that grow onto the kidney, and this one is almost ovulating one, showing the spora body extrusion. So that means the M2 stage oocyte. This one still attaching the follicular wall, but showing the expansion of the chemo cells. It's another marker for the normal response to the HC stimulation. So based on this success in basic and translational studies, and also we confirm this safety using so many animal studies, then we move on the clinical application of the IVA. So this one is our scheme for the clinical application of the IVA in the PO patient. Briefly, first step is ovariectomy under laparoscopic surgery. And then we can treat ovarian fragments with a P10 inhibitor and a PI3K activator for 2 days. So as an option, we can do the cryopreservation of ovarian tissues. Nowadays, we are using a vitrification method. And during the cryopreservation, we can confirm whether the patient has residual follicles or not under the histology. And also, and after that, we actually the culture, we grafting back all the ovarian fragment to the patient, again using the laparoscopic surgery. And then after that, we have to do the proper ovarian stimulation to get a mature follicle, and then we can perform regular in vitro fertilization and embryo transfer to have the babies in a PO patient. So when we published the second paper, of course we got approval from our university and Japan Society of OBGYN, and then we enrolled 83 of PO patients. The average age was around 37, and their duration of amenorrhea was almost 6 years. And from now, I'm going to show the details of our clinical approach. The first step is ovariectomy under laparoscopic surgery. The important tip is we have to minimize the usage of electrically cutting hemostasis to avoid the damage of the residual follicles in ovaries. And together with a fallopian tube, it will be a site for the transplantation. And if we remove only one ovary, at the beginning we did both side ovariectomy, but later on we changed our policy to remove only one ovary. And then how can we decide which side? So the answer is based on the prior follicle growth history. And following this criteria, we can expect presence of the follicle under the histology was more than 70%. So actually, in our cases, more than 50% of the patient had a prior follicle growth history in one side or one side dominant, so predominant. So that's why we can select the which side ovary based on this past history. And also, if the patient has not had the previous record, then we can decide based on the size of the ovary. So here you can see the large size ovary had a higher potential of the presence of residual follicle, and the number of the residual follicle depends on the size of the ovaries. And this slide shows the localization on early follicles in ovarian cortex. Unfortunately, this is not human ovary. This is a cat ovary, but the construction is completely same as a human. So here you can see the small follicles. Small means primordial, primary, and early secondary follicles are all located within 1 to 2 millimeter thickness from the surface of the ovarian cortex. And large antennal follicles are located deeper, the medulla on the ovary. So we dissected ovarian cortices containing residual follicles by removing medulla like this, and then cutting into the small stripes, 1 centimeter square, with 1 to 2 millimeter thickness, where the residual follicle located, like this way. And as an option I already mentioned, we can do the cryopreservation by vitrification method. And from one pure ovary, we usually can get 6 to 8 pieces of ovarian cortical stripes, and then we do the histological analysis using 10% of volume of each ovarian stripes to detect the residual follicles under histology. And then we further fragment ovarian piece into tiny 1 to 2 millimeter cubes, and then treat it with IVA drugs, P10 inhibitor and PI3K activator. here, I cut the ovarian piece into tiny 1 to 2 millimeter cubes and then put onto the membrane of the cell culture insert and covered by a very thin layer media to allow to the tissue culture. And before transplantation, we wash and culture. We wash an ovarian cubes by warm culture media alone to avoid introduction of the reagent inside the body. And also, then we transplanted beneath the serosa of the fallopian tube of these ovarian cubes. Why we chose beneath the serosa of the fallopian tubes? The reason is the site is really have the high vascularization. As an OB/GYN doctor, we always facing ectopic pregnancy with massive bleeding now. So, and also, it is really convenient for the transvaginal ultrasound monitoring, and it's for the oocyte retrieval. We can do this all completely same way as a regular in vitro fertilization. So this picture is showing the auto-transplantation ovarian cubes. So here I cut the serosa and making a pouch between the serosa and fallopian tube. Then graft multiple ovarian cubes beneath the serosa of the fallopian tube. And then wound can covered by the interseed, or of course we can make a stitch suture to avoid the follicular growth from the grafted side. So now I'm going to show the movie. Of the transplantation of the ovarian cubes. So here is the uterus, and this side already we cut it out the ovaries, and this side is a contralateral side. We still have ovary here. Then picking up the serosa of the fallopian tube, and then inject the saline to make a hydrolysis between the tube and serosa of the fallopian tube. Okay. Then cut the serosa. And making a tunnel, space between serosa and a tube, like this way. And continue to making a site. Maybe we can prepare 3 to 4 sites per tube. Okay. Then now we are using this type of special device. We put the tiny ovarian cubes into this device. It's like a syringe. Then push in all the ovarian cubes like this way from the incision of the serosa. And we can graft in back the opposite side, again like this way. Now you can see the grafting ovarian cubes under the serosa. And then we stitch the wound by very, thin needle. that's it. We continue to do. Okay, let's go back. Okay, now you know we are using this type of the device. We put ovarian cubes inside of the tube and then push into the incision ovarian fallopian tube and then push out all the ovarian cubes. So, but I think we have still issue on that way because here you can see that all the grafting ovarian cubes connecting each other and making a clot. So we did one experiment. So using the day 3 mouse ovaries, and then they transplanted like individually one ovary left side, and the right side we transfer back 2 ovaries together, 3 ovaries together, 5 ovaries together. So then in the case of the 5 ovaries together, so you can see the ovarian weight is getting decreased. But if we put back 5 ovaries separately, like this way, so then the ovarian size, ovarian weight didn't change at all. And then we checked the number of the mature oocytes obtained by the grafted ovary. If we put 5 ovaries together, so unfortunately the number of the mature oocytes now is really totally declined. And also abnormal and degenerated, the number of the oocytes is really increased in the case of the 5 ovary put in together. So, and it's caused by maybe by ischemic issue. We measure the CD31 as a marker for the vascularization. So in the case of the 5 ovary together, the expression is really suppressed. So that's why, unfortunately, if we put all the ovarian cubes together, it may cause trouble. And then now what we are doing now, we try to separate it out as much as possible after using this device. And here's I'm talking about the patient follow-up protocol because laboratory work and surgery work is really important in the PO and the IVA. But after operation, the follow-up, the ovarian stimulation is really also important in the IVA project. So we monitor the follicle growth weekly to bi-weekly under the transvaginal ultrasound and measurement of serum estrogen and gonadotropin levels. And after normalizing NRH levels using AP pills and GnRH agonists, this is the one on the tip. I will explain later detail. And follicle growth was promoted by recombinant FSH and HMG under GnRH agonist or antagonist protocols. And after HG stimulation, we can get an mature oocyte under the regular IVF protocol. So actually, the tips of ovarian stimulation after IVA is, the in-POI patient, due to the absence of antrum follicles before and immediately after an IVA, in the first sign of the follicle growth is elevation in estrogen. We cannot detect the follicle under ultrasound. We can only find the elevation in estrogen from the basal level. So without ovarian stimulation, the follicles can grow spontaneously, followed by the decline in FSH and LH levels based on the negative feedback of estrogen. It's written in the textbook, right? And however, in most cases, the decrease in LH levels is inadequate. So then it causes an early luteinization and arrest on follicle growth and oocyte degeneration. Actually, my friend in Japan, he showed this data. And if the follicles receive the chronic high LH stimulation, it causes a decline of expression of GDF9 and in the oocyte and a decline in expression of FSH receptor in the granulosa cells. It causes poor response for the FSH stimulation and less than follicular growth. So that's why, how can we stimulate an ovaries after an IVA? The answer is normalize an NRH level by supplementation estrogen and/or estrogen plus progesterone with induction of withdrawal bleeding first. And then after confirmation of the LH level is less than 10, so we can simultaneously start treatment of the patient with a GnRH agonist. Now, Japan, daily GN antagonist injection is really expensive. That's why we use a GnRH agonist. But of course, we can use GnRH antagonist also. And similar to the short protocol in IVF protocol, we can treat a patient with a recombinant FSH or pure HMG to avoid LH contamination, and for more than 2 weeks. In a regular patient, in a regular IVF program, we treating a patient around 10 to 14 days to have a mature follicles. But they are PI patient, and they don't have any antral follicle before the stimulation, ovarian stimulation. That's why it takes very, very long time. More than 2 weeks, we need to continue to inject an FSH. So here I'm showing that when I published in the second paper, among 83 patients, ovary grafting was performed on 46 patients, and follicular growth was found in 28 out of 46 patients, almost half of patients. Was found in and containing a residual follicle is important, and based on, of course, histology. And no follicular growth was observed at that time in the patient without residual follicles and the histology. And after that, we performed the interfertilization, and the embryo were cryopreserved at day 2. And then sewing embryo transfer was performed in a patient, and others were accumulating in cryopreserved embryos at that time. And 3 out of 8 patients became pregnant after an embryo transfer, and unfortunately one was a miscarriage, but we could get 2 successful deliveries. So this is the first baby in the world after an IVA, because in Japan we have to do everything, IVF and monitoring babies and C-section. And that's why I did a C-section by myself, and then I'm holding this baby. So now, actually, she agreed to show this picture. She's the first patient, mother. And now he became more than 4 years old, and he is totally healthy. And of course, mother is healthy. And now she wants to have a second baby. So we have a cryopreserved ovarian tissue. So then we already performed the second time the ovarian transplantation. And very lucky, and she could get an embryo already. And now we are planning to embryo transfer maybe this month or the next month. So hope to have a second baby. So here I'm showing the current clinical outcome on IVA. We performed ovariectomy in 152 patients. And under the histology, we could find the patient with the residual follicles in 96 patients. And the number of the patients with IVA grafting with residual follicle is, and the follow-up time is more than 6 months, is 70. And without follicle, even without follicle, 16 patients want to do the entire process on IVA. And we did 60 patients. And here's the results of the follicular growth in Semineri experience. So actually, result is really apparent. Here, if the patient had residual follicles, more than 60% patients were responding. But if patient had no residual follicles, actually we could get a follicles in one patient, but other patients didn't respond at all. So that's why our histological analysis were effective to predict an IVA outcome. So now the indication of IVA treatment is the patient with residual follicle. And of course, we prefer to enroll the young PI patient without oocyte aging, because at least until now, we can say this approach cannot fix the aneuploidy issue in the aging oocyte. So that's why it's really difficult to apply this approach in totally aging, like 47, 48 patient. Of course, they may have a chance to have a much higher number of oocytes, but most of them are unfortunately aneuploidy, and this approach cannot fix it. So that's why we prefer to enroll the young patient. So the next question is how can we predict the presence of residual follicles? So the answer is a recent follicle growth after even diagnosis of the POI, or short duration of amenorrhea. Yeah, maybe 3 months, 6 months, 1 year. So also, if the patients still have the positive MH level, it is another good sign to have a residual follicles. So if we measure the duration of amenorrhea in case of the presence of residual follicle, the average is around 4 years. And the residual follicles number will decrease within duration of amenorrhea like this. So, but you can see from these figures, the variation was pretty high, like this. So in some cases, even more than 9 years of amenorrhea, they still have residual follicles. In contrast, within 1 year, some patients already lost every follicle. We could not detect the residual follicle under histology. So, of course, this may be caused by the totally different causes in POI. It's really difficult to predict only based on this criteria. But we can say something to the patient. And here I'm going to show the result of an IVF after the IVA. The success rate of oocyte retrieval is more than 19%. And the fertilization rate is more than 70%. And then we could get a high quality day 2-3 embryos, more than 40%. And here I'm summarizing the overall outcome. I'm including all the data from the beginning. We performed 116 patients with grafting ovarian tissue after an IVA. And their mean age was around 39 years old. And we performed embryo transfer in 28 patients, and the pregnancy rate is around 36%. And miscarriage rate was 40%. And we could get 6 babies. So here is an IVF outcome in 400,000 cycles during the 2014 in Japan. This is a public record. So if the patient age, this is a day 2, day 3 embryo transfer. So if the patient age around 39, so both success rate of pregnancy and pregnancy rate is around 30%. So pregnancy rate is around 36%, and miscarriage rate is 40%. Of course, the number is not so many, but I hope our outcome is also acceptable as compared to the regular IVF treatment. So actually, this is a science. It is important to have a reproducibility. So we already, this reproducibility could get in China and Spain and Poland groups under our guidance. Now, as you see in the Professor Hsueh's lecture, China had 2 babies, and Spain has 3 babies, and Poland had 2 pregnancies, hope to have safe delivery. Actually, the success rate in Poland is pretty high. At that time, I visited in Poland, and we did 4 surgeries, and 2 already became pregnant. And 1 patient had a couple of numbers of Brassis stage embryos, almost guaranteed, because their age is all under 30, no oocyte aging. So they could get a very high pregnancy rate. So this picture already interested by the Professor Hsueh, and I just want to remind. First, we expect to have a follicular growth after 6 months of the surgery, because it takes around 4 to 6 months to in a human to start from the primordial to a puberty stage. But in contrast, our expectation, in some cases, we could get an early follicular growth before 6 months of the surgery. Then, as explained by Professor Hsueh, so we try to find out the mechanism, and then result is this hyposignaling pathway. So here I'd like to simply summarize the two-step follicular stimulation in IVA. Using the PI3K signaling stimulation, we stimulate a dormant primordial follicle to activate to be a primary stage. And using the hyposignaling suppression, chop into the ovarian tissue, tie into tiny cubes. Then we stimulate the secondary follicular growth to be an antral follicle. So this slide is also shown by the Professor Hsueh. In our original method, we did 2 surgeries. The first oophorectomy, and then after the culture, we did transplantation and by the second laparoscopic surgery. But if we try to do the hypodisruption only in case of the DOR or early POI patient, diminishing ovarian reserve, poor responder patient, early stage of the POI patient, they still have the secondary follicles. That's why we could expect the follicular growth without doing the drug treatment, PI3K activation. So just remove the maybe the partial part of the ovarian cortex and fragmented into tiny pieces and directly grafting back to the patient. Of course, we can graft to the fallopian tube, but especially in case we can graft back to the ovary, remaining ovary. The reason why we chose the site of the fallopian tube in the PI cases, the reason is if we try to remove the ovary and laparoscopic surgery in a PI patient, they didn't cause a bleeding. They have very small bleeding. That means blood saturation in ovary is very bad. So that's why in such cases we thought it is really difficult to have a neovascularization after the grafting back to the ovary. But ovary itself is a really good site. They have a niche to the follicular growth. That's why in this type of the early stage of the patient, their blood circulation should be very nice compared to the severe case of the POI. And the ovary itself has a very nice niche for supporting follicular growth. That's why if we graft in back the remaining ovary, we can expect a spontaneous ovulation and expect the spontaneous pregnancy. So now I'm going to show another movie here. So what we are doing is now cutting part of the ovarian cortex from one ovary using fine scissors. Just try to remove the ovarian cortex, not try to include a medulla. So if you try to obtain only the cortex part, the bleeding is not so much. It looks like this. Then opposite side, we are collecting the ovarian cortex again. just try to remove the cortex alone. Okay, then we try to make a space between the cortex and the medulla. And then, yes, and using the scissors and the mirror and the forceps, we try to make a space between the cortex and the medulla, like this way. If you have massive bleeding, you can do a little bit in the coagulation. And also, we are grafting back the ovarian cubes, also into the beneath the cellus of the fallopian tube, both sides. And then, yeah, this way is the same as the previous one. We just using the special device, putting the ovarian cubes into the beneath the cellus of the fallopian tube. And then in the ovary, using this device again and push into between the cortex and the medulla, and then push in all the ovarian cubes. Like this way. And they're covered by the interseed to avoid a follicular loss, and ovarian tissue, grafting ovarian tissue loss. Okay, that's it. So, yeah, this slide already introduced by the Professor Hsueh. The drug-free IVA, this method, and also the orgasm grafting, is of course limited to the patient with who likely to have a secondary follicle. Should be the patient with diminishing ovarian reserve and or the early stage of the PI patients. So, but there are several advantages. The minimum damage to the ovarian blood supply, as you look like, and no need to use a drug treatment, and avoid the potential follicular loss during the culture. Especially large secondary follicles is really, going worse during the culture. And we just need one laparoscopic surgery. Maybe we can finish within 2 or 3 hours in total. And it could have a spontaneous pregnancy. So now the Spain group already succeeded in three cases. So these are my collaborators. I especially thank Professor Hsueh for 15 years collaboration. And he discovered so many things in the basis of the IVA project. And as he explained, I moved to the previous, the national university to private university to perform the IVA. Now, fortunately, I could get a new full professor position in this new university. So I will continue to the IVA at this university, and now this university is totally brand new one, and we are seriously looking for the new PhD student and fellows from next April. So if you want to join our IVA project, I'm really happy to work with you. So thank you for your kind attention.
Now the paper is open to discussion. Any questions or comments from the audience?
Buyurun.
Bir saniye. Onu canlı yayın olduğu için onların da duyması için kullanmanız gerekiyor.
Thank you for your excellent presentation. First of all, I want to ask that, like these follicles are the dormant follicles, the last follicles in the ovary. So, could we say that the aneuploidy risks in these follicles, in these patients, higher than the other patients with the same age, but does not have ovarian insufficiency?
Sorry, too noisy. So, can you speak louder?
The aneuploidy risks in these follicles, in these patients, could it be higher than the patients with same age, but does not have ovarian insufficiency? Because of that dormant follicles, these are the last follicles in the ovary, so the aneuploidy risk, could it be higher than the normal follicles? I want to ask this.
Just hold on, because you have to use the microphone. Mikrofonu alabilir miyiz? Because okay, you go ahead. I'm sorry. They say you go ahead.
Okay.
Right. Yeah.
Okay. Actually, it's really difficult to answer because we haven't checked the aneuploidy in all embryos. So, but our previous experience, the success rate of the pregnancy is not different. I mean, if we think about, if we treat in the same age of the patient, so the success rate of pregnancy in POI patient is the same as other causes. So that means aneuploidy percentage may be same, but unfortunately we didn't check the aneuploidy in our embryos because Japan is still not allowed to do it. So that's why. Yeah.
Buyurun Bülent abi.
Dr. Kawamura, Dr. Ergun from University of Istanbul. Thank you very much for your excellent presentation. I would ask you, after removal ovarian cortical tissue, we prepare the tissue in small pieces and we put it to the tubal area. After that, how long we should wait? We should wait for E5 IVF treatment.
Okay. Actually, I think in the case of the early stage of the POI or DOR patient, who when we expect to have a secondary follicular growth without drug treatment, maybe we can say you can wait 2 to 3 months for the initial stimulation because it requires some certain time to secondary follicle go into the pre-antrum stage, right? And then if we stimulate, so we can have a much high number of the antrum follicle, we can expect to get a high number of the oocyte. But in case of the the original IVA, it's really difficult to say because they may have a secondary follicle, but they may not have a secondary follicle. It's hard to predict. So that's why, as shown in a slide, so some patients really responded before 2 months of the, after 2 months of the surgery. So that's why in the original IVA approach, I recommend to start immediately after the surgery. But in case of the DOR and early stage of POI patient, as I explained, because they still have the basal level of the follicular growth without doing this approach, right? So, but the point is that we expecting to obtain a much higher number of oocytes from such kind of patient. So for that purpose, maybe we need to wait a couple of months to have a much higher number of pre-antrum follicles.
Buyurun.
I again want to thank you for you both about that excellent speech, and I just want to say that I really missed listening to you both. And I want to ask about the follow-up. I mean, after all that procedure, how do you follow up the follicular growth? I mean, we know that AMH is not working on that way properly, and we just have all ultrasounds. And also now we have that FSH radioactive marked receptors, but it's not that regular. No? Then now I've seen that you mentioned about that GDF9, and there are some studies about BMP15. What do you think about both of these two markers?
Okay. So, practically, what we can do easily is just continue to monitor the estrogen level. Now, of course, I already mentioned that maintain the RH level to be lower than 10 is really important to avoid early luteinization and follicular growth arrest and also degeneration. But if we can maintain the RH level to be lower than 10, the next issue is we always need to think about the vascularity in the follicles. This is a really artificial condition, right? So even in the regular POI patient, their vascularity is very poor, and even if the amount of the FSH, serum FSH level is pretty high, but the amount the real amount of the FSH going to the follicle is very limited due to the poor vascularization. So that's why we try to inject the FSH more than 300 inter-unit per injection, and then try to maintain the FSH level maybe more than 30. And also final injection, final stimulation HCG is also very important. It's only one injection should be very effective. So that means we are giving the threefold higher amount of the HCG in the regular POI IVF protocol. We are giving 15,000 IU on HCG. So we failed it. We cannot get on oocyte. So that's why such part is also very important. And under such protocol, it's similar to the short protocol, right? Just confirm the RH level. And then if it is fine, we are giving the patient with an GnRH agonist together with an FSH injection, and just continue to maybe 3 or 4 weeks. And then if failed, what we are doing is we induce the bleeding again. And then after that, we start the stimulation and then continue. And based on our experience, the longest patient is they still respond in more than 2 years. Yeah, so this is the practical way of what we are doing.
Hi, my question is, so first of all, I have 2 or 3 questions for you, but the first one is, what kind of prenatal test did you use during your pregnancy follow-up for those patients?
Clinical test? After pregnancy, you mean?
Yeah, after they conceive.
Actually, it's the same as a regular protocol. Yeah, we haven't done any special one, but afterwards, of course, we are trying to collect every samples to check up whether it is normal or abnormal. So, but everything the same. I just monitor the fetus following the regular OBGYN protocol. Yeah.
Just a routine follow-up for that. Mm-hmm. And also, when they delivered the baby, the follow-up after pregnancy was the routine, like annually? Do you need to see them?
I always need to ask the pediatrics and physicians. They are reporting us, and by recording their normal development, other things, and yeah, seems to be fine. But such part I need to ask them. So.
Okay, thank you.
Buyurun.
It was an excellent presentation, actually, Kawamura Sensei, Hirashima State, Turkey. My question is a little bit technical. When I look at your study, you enrolled, 83 patients to your study, right? Mm-hmm. And you had successful cases for 46 patients.
Who has a residual follicles.
Yeah. I studied about tissue culture in Japan, Gifu Daigaku, for 2 years. And I know that it's very difficult to work on, tissue culture. What's the reason that around 35 patients, what happened there? Is it the problem of infection or something else? that
You
you
mean
didn't
the-
enroll, the study? 83 patients and you accepted 46 patients. But what happened to the other patients?
So you are talking about the patient without
yeah, you
follicle,
didn't
right?
succeed. What
Yeah,
happened?
it's already occurred before our treatment. Yeah, when we took out an ovary and did a histological analysis, and then we couldn't find any residual follicles. So it's already occurred before our treatment. So that's why it's really difficult to say what caused entire follicular loss within certain time. But actually, in our cases, it also includes Turner mosaic syndrome and X chromosome abnormalities, iatrogenic one, and also the autoimmune disease, all including. But due to the very limited number of the patients, if one try to divide in a subgroup, the success rate is very, up and down. It's difficult to say. Maybe in future, I think maybe in the case of the genetic one, so the success rate should be very low. But we don't need to say, we cannot say at this point. So maybe it's, if we could have a much higher number of patients, maybe we can answer your question. And also, you are in the Gifu University in Japan. Okay. The tissue culture is, of course, not so easy. But in your cases, it's just only 2 days, 48 hours. And also, to success in a tissue culture, we cut into the very tiny piece in an ovary, and then covered by the very thin layer of media to allow to maximize gas exchanging. So it allowed, usually it allowed success in the tissue culture, even other organs. So that's why I don't know what you did in Gifu University in Japan, but I can say our approach, our method is successful until 48-hour culture.
So there is one question from live transmission about the quantitation of the primordial follicles. So is there a dose-response relationship with if there is, is there a dose-response relationship with the number of, dormant follicles and then the response?
Yes. I cannot give the correct answer based on the, the dose response. But basically, if the patient has very limited numbers of primordial follicles, they may not succeed in follicular growth. But they have a much higher number of primordial follicles. We could get so many times of the follicular growth after the surgery. But again, it is very limited number of patients. We cannot say it's really, dose response, it is responded by dose. But theoretically, of course, it should be. Yeah, actually, we have rough experience on that. Yeah.
Buyurun. Şuraya.
Thank you very much for this excellent talk. Did you have opportunity to test these two methods? With the drug activation versus the cutting the ovaries in the same patient in human? Transferring one ovary, the drug-induced ovaries, and to the other one, the cut pieces.
Okay, thank you for your question. Actually, in the severe PI patient, PI patient, who is a single woman, what we did is one side we removed the ovary and freezing, and then the other side, but we cut the surface of the ovarian cortex on site. Okay. Then after that, we ask the patient, would you like to, try to retrieve an oocyte in the remaining ovary, and then compare the historical control, and then, unfortunately, in the case of the severe PI patient, it was not successful. Yeah, no, more than 20 or 30 patients. Yeah, it was not successful. But in the case of the DOR patient, now we are doing a clinical study together with my friend in Japan. So because they have a certain basal level POI is very apparent, but without doing this approach, they may have some, successful pregnancy. So that's why now we need a much higher number of patients to make a statistically analysis. But seems to be working, but I cannot say now. Yeah, thank you.
Because for defining subgroups, for drug-free IVA procedure, I guess it's also very critical to define concisely. So what is the definition of occult or early POI? So what is your definition?
In my clinical study, we are not enrolling the patient at early POI stage because it's hard to say sometimes. Yeah, even within 3 months of the amenorrhea, in some cases, their residual primordial follicle is completely lost. So that's why we are trying to enroll the patient with irregular menses. Yeah, it's kind of the diminishing ovarian reserve. Their IMH level should be lower than 1, 0.05, 0.1. And
well, this is the definition for DOR, right?
Sure, yeah. So we try to avoid including the early stage POI patient because we cannot exactly predict the presence of the secondary follicles. So in such patient, we can do the regular IVA treatment. But we can expect, but maybe if we expect to have for sure the secondary follicles, we'd better to in the first stage we'd better to compare using the case of the DOR patient.
Okay. Thank you very much for your nice work and contribution to the ovarian physiology and our prospects. I have 2 questions. One is the molecule you are using, like P10 inhibitor and the activator, are simple molecules from Sigma company, or is it a developed drug yet?
Actually, P10 inhibitor is a chemical. It's available from maybe more than two or three companies. But its biological activities are a little bit different among the companies. So that's why we are checking its bioactivity using animal studies. But the issue is 740YP, the PI3K activator. It is very unstable, really unstable. And sometimes it shows 100% bioactivity, sometimes it shows almost 0% activity. Even the company certified, if we try to purchase the company certified one. So that's why, again, we are doing the animal studies to confirm its bioactivity. Then we can use it.
And the second question is, in one of your papers, you mentioned the histological sectioning for each patient. Do you still do that? I couldn't understand that you are still taking pathological sections, whether the patient has still follicles, primary follicles or not. Do you do right now?
We are doing in every patient. As I already shown you, we took out the ovarian cortex, right, and making 1 centimeter square cubes, and then using a 10% volume of each one. So then we did the histological analysis.
If there is no follicle, you don't go.
We need to, consult the patient. Of course, if we can find a residual follicles, no problem. We can, continue to all the work. But if we don't have the residual follicle under histology, we always asking the patient what we will do. And of course, you can try, but success rate is very low. And you can give, it's always asking, depends on the patient to reply. Some patients want to continue to, but some patient doesn't want.
Last question, with the histological section and the result of IVF treatments, let's say,
understand.
Is there a correlation between
you mean the first, after the cryopreservation?
You make some kind of grading, let's say, or I can't say, maybe 3 follicles per high power view, and the result of the transplantation. Is there a correlation with that?
Actually, it's really difficult to, because we are doing a histology, right, individually. But, for example, this is a tissue. So we cut here and confirm the follicle is here. But we are using this part. But there is no guarantee to have a residual follicle in this part, right? And the piece is connected like this way. And this one may still have the potential to have a residual follicle, even if we cut here to confirm this is no follicle. So that's why this approach, what we want to know is whether patient have residual follicle or not. Yeah, distribution is really difficult to say. Yeah, because in some cases we have experience. When they did the first surgery, unfortunately we could not get a follicular growth. But second surgery, we did it. So we are using the different pieces, preserved one. They suddenly start to grow the follicles. But we always predicting based on the histology, presence or absence. But it cannot tell you about the future follicular growth. It's really difficult to say. So that's why only the purpose is we are trying to find a patient entirely no follicles in the ovarian cortex. Then we can discuss with the patient whether you will go on or give up any other treatments.
Son soru olarak sizi alalım.
My question is out of topic. Do you have any experience on the patients with immature oocyte syndrome to whom we cannot obtain any mature oocyte in their recurrent IVF attempts?
You are talking about resistant ovary syndrome.
No. Actually, good ovarian reserve, but despite HCG, no M2 oocytes. So low maturity or zero maturity rate.
In IVA cases, you mean?
No, in regular.
In regularly?
In general, I guess.
In generally, actually, I know we have experienced one case. It's totally immature, even given a high amount, maybe 30,000 HCG IU. Unfortunately, we could not induce maturation, even under the IBM culture. So then, unfortunately, we have to give up to treating such kind of patient.
Kazu, so I would like to conclude with my last question to you. I mean, since you are the pioneer of this technology, and since you are not only a clinician, you are also the scientist, along with Professor Hsueh, and the physician should have the responsibility. So what would be your final message to our gynecologists, reproductive endocrinologists, in terms of the indication of treatment? So I'm just a little bit, scared of misuse of this technology, even suboptimal responders, even normal responders to increase the number of oocytes. The first question, to avoid the misuse of this technology. I'm just afraid there's so many gynecologists with limited knowledge, with limited background of the science, and they will be cutting and all this. So you have to avoid this. And secondly, and most importantly, what should be the minimum setup to use this technology? And some physicians will show up just in the OR, making funnel steel incision, and they doing such technology. I do appreciate how much effort is in the lab, so I would kindly ask you to comment on these two issues. Thank you.
Okay, thank you for your important question. As for the message, actually, you already know the POI is a progressing disease. We cannot recover the number of the follicle in ovaries. Anyway, they are going down. So actually, we can do that kind of education in young women because the incidence is very high, 1% of women. So the initial sign of the decreasing ovarian reserve is irregular menses. But in a woman, irregular menses is a very common one. So if once experience, they never worried about the irregular menses. Maybe some kind of caused by stress or other things. So, but 1% to women, and the ratio is really high. So that's why I totally would like to recommend, if the young woman experience irregular menses, please check an AMH level. So if AMH level is lower than the normal age, so they may have a risk to go into the POI. So if the woman realize such situation, if the woman has a chance to marriage, so I totally recommend to have babies earlier. And also, if they are totally single, you can consider the oocyte cryopreservation, or even the ovarian tissue cryopreservation, and before going to the severe condition of the POI or even the DOR patient. So in Japan, we are trying to do it, but unfortunately, our ministry and is not allowed to do it. And in the school days, the old young kids is educating only contraception. We'd better to have such kind of education. But I don't know here it is possible, but it is really, nowadays we can do the cryopreservation outside or even ovarian tissue. So it is, hopefully to many, almost all the women in this country and even in the world would like to know about such kind of risk and try to think about their future, family planning. And also, your second question.
Setup.
Yeah, setup. Actually, this is, of course, really important. So this is, science, and this is still the clinical study level. So that's why, ethical issue and approval and other things is really important. So, of course, try to get an IRB approval is really, necessary because, at the application, so many people, many different people coming from different fields, talking to each other, whether this is safe or not, and also other issues. And then finally, okay, you can go on. So then this process is really important. Of course, you can try by yourself very easily, especially in the just cutting grafting back. But under the missing such process, it may cause trouble in future. So that's why most important thing is try to get official IRB approval from, I don't know, government, university, or OB/GYN society. It's most important. And then setting up is, in that aspect of the setting up, there's so many tips behind. Just reading our paper, just try to repeat it is really dangerous. If you think about Japan is a pioneer for the iPS cell. So can you establish an iPS cell by your hand without just reading a paper? Maybe not so easy. Yeah, same thing. So if you try to establish it only by your hand, maybe something going wrong. It's really difficult to tell you the details behind our technique. So that's why, like Professor Hakan, this communication is really important. So without this type of communication, you fail it. Maybe you fail it, but it's not coming from this approach itself. Maybe something missing by try to repeating our approach, but it's caused trouble in the estimation of the effect of this approach as a scientific viewpoint. So that's why we really appreciate to, if you want to do it, collaborate our team to entirely, completely copy our protocol. Then please, try to repeat it and try to, have new babies. Thank you.
Thank you so much, Kawamura. Thank you so much.